Okay, now we moving forwards, we can look at the neuromuscular blocking drugs, whereby in a way they want to make it easier to understand and remember. So this drug are used mainly in surgery or people having a critical care because they want to relax the skeletal muscle. Okay, but they do this by interfering with your neuromuscular transmissions of your acetylcholines. Okay, remember when they have activations of acetylcholines, that means they make it active. Okay, so what we're doing now is because we want to have a relaxed muscle. So when you want to relax your muscle, what you do? You block your acetylcholines. So your acetylcholine don't bind, so they will have a relaxations of your muscle. So clinically, they are always used together with the anesthesia, not on their own. Okay, so now when they have a three main types of this blocker. One is the non-depolarizing blocking agents. Okay, so they block the acetylcholine receptor. Okay, so just imagine the receptor have been blocked. Number two, they have a depolarizing agents. Okay, to reduce the polarizing of this particular SAH. Number three, they can inhibit the SAH release. So instead of like we block at the receptor, we inhibit your acetylcholine secretion as well. Okay, starting with a non-depolarizing blocker. So these are a classical, we call it as the cura-like drugs. Okay, so think about tuberculines, where its original derived from the cura poison as well. Okay, so they can be used actually. If let's say you are looking at this picture, actually, is that they can be used as an arrow by the Amazonian tribes. Why is because if let's say you still remember, if let's say you watch a movie, I'm not sure about you guys did watch this kind of movie, so they actually use this kind of poisons to like cause a numb and then during hunting season as well. Okay, so this agent basically they competitively block your nicotinin SAH receptor. So when they block your receptor, what happens is that your muscle, your skeletal muscle will become relaxed. So when your skeletal muscle have been relaxed and then they causes this competitive block of your nicotines, they prevent this acetylcholine from triggering the contractions. Okay, so a modern synthetic versions like pancuronimes and your vacoramines and your atriochorimes, basically they are more refined as well. They can be widely used in the operating theater, and most importantly, it can be reversible with these anti-cholinesterase drugs. For example, we can use your neostigmines and the phagostigamines, whereby they helps to restore your muscle activity by increasing your acetylcholine level as well. So on the flip side, we can have a depolarizing blocking agent. For example, like we can use the succinylcholines and your diacantoniums as well, whereby they can act as a acetylcholine mimics, and whereby they can also bind the receptor that initially cause your muscle contractions. Okay, unlike normal acetylcholines, they aren't broke down quickly. So they sit on this receptor and then they keep it depolarized, making the muscle fiber unresponsive to further the stimulation as well. So this is what we call as a depolarization block. Okay, and it can leave the muscle flaccid as well. So it's kind of like useful in a very short procedure, like during the trachea intubations when you want to put the trachea intubation. So you can use this method as well, but it must be very use precautious. Okay, because if let's say your cholinesterase, this cholinesterase basically is the enzymes that to break down your acetylcholines, isn't it? So if let's say it inhibit, this block can become dangerous. Okay, if let's say have been prolonged. So your neuromuscular block is a very powerful tools. So if let's say we are using the non-depolarizing one, they have a seek and lock. Okay, so your acetylcholines couldn't get in. While a depolarizing one, they will jams the lock opens, okay, until the system have been shut down. So it really depends on how we want to control the muscle activity in surgery or maybe in the emergency care. So we can pick the tool that fit the situation as well. Okay, now we can start talking about how the acetylcholine, okay, your SCH can be released from the blocker, okay, and why does it matter in the clinical setup or in the pharmacological? So there is a two most potent agents that can prevent your SCH to release. First is your botulinum toxin. Yes, it's the one that basically botulinum toxin. If let's say you recall, people always use it for Botox. Okay, the one that people inject in the face. Okay, and also we have this beta bungatorix. Okay, so beta bungatorix is a venom kind of like components in certain of the snake. Okay, for example, in the snake, it can release this beta bunga toxin as well. So this toxin, they target the snare protein, okay, whereby it's quite essential for the recycle fusion as well. So basically, what happens is that they will prevent the neuron from releasing the acetylcholine contains package into the synaptic cleft. Okay, remember, for you to activate your parasympathetic, so you need to have your acetylcholine to bind towards your synaptic cleft, right? So without this release, the muscle fiber will never get the contract signal. Okay, so it can lead to a flaccid paralysis. Well, if let's say we talk about this botulinum toxin, or we call it in the short form, we can call it as a Botox. So it can be used as a therapeutic methods whereby they control in a very controlled kind of like dosage. You can use it for the muscle spasticity. Okay, that's why it can cause to remove the wrinkle as well, and sometimes it can cause the chronic migraines, and also you can use it for this cosmetic application as well. Well, the other hand, for the beta buga toxins, they serve more in experimental model because currently they found out to be a very powerful paralytic effects. So we are yet trying to figure out how we can utilize this particular beta buga toxins in the pharmacological aspect as well. So a part of it, now we're going to look at instead of like we block the acetylcholines, what if we boost the presence of your acetylcholines? That's means instead of like we blocking it, we cause it to release more acetylcholines. Okay, so this is the job of this anti-cholinesterase. Okay, because cholinesterase is to block. Okay, to break down, it's an enzyme to break down the cholines. If let's say we have anti, that's mean they're going to prevent the breakdowns of these cholines. Okay, so this drug is basically used to inhibit the enzyme of your acetylcholinesterase, whereby this particular anti-cholinesterase is an enzyme that responsible for breaking down your acetylcholine in the SNPs. So by blocking this by using this anti-cholinesterase, okay, this drug basically they can this drug will let the acetylcholine to stick around longer, whereby because they didn't break it down, right? Okay, so they can stick more longer and then enhance the cholinogenic signaling as well. So we always try to classify this drug into a short acting. For example, like adrenaline, okay, it's a short acting as well. So this adrenaline basically they act as a short acting. Then we also have a medium acting. We have the neostigmines and then the phagostigmine as well. So for some of the cases, we have an irreversible type. So we have these organophosphates whereby they use in the pesticides or in a nerve agent as well. Okay, so some of it they also have a systematic effect as well of these anticholinergics include some of the effects, for example, like bradycardia, hypotension, and excessive secretions and bronchoconstrictions, even the gastrointestinal hypermotility as well. Okay, so you have to remember, if let's say we are preventing it from secretion, so they're having this kind of like side effect. And because they are ramp up all the the reasons why is because they ramp up all your parasympathetic response. So at the neuromuscular junction, they can increase the twitch tensions and can cause the depolarization block if your acetylcholine build up too much. Okay, now we're moving to the very last slide. Okay, we have one of the disease, myasthenia gravis. So this become important in the context of disease, for example, like myasthenia gravis, whereby it's an autoimmune disorder. Okay, where the body produce antibody to destroy the nicotinic acetylcholine receptor at the neuromuscular junctions. Okay, if let's say we talk about autoimmune disorder, that means your body have antibody, isn't it? So if let's say your antibody is supposed to be attacking the foreign object, if let's say you're having a problem with autoimmune, they didn't attack the foreign object, but they attack towards your own body system. If let's say the most famous autoimmune disorder, if let's say you know Selena Gomez, so basically she have autoimmune disorder, but not myasthenia gravis. Okay, so you have other types of autoimmune disorder. So I just give an example of this autoimmune disorder. So for myasthenia gravis, this antibody that produced in your own body system, okay, instead of like they destroy the foreign object, they go and destroy your nicotinic acetylcholine receptor at the neuromuscular junctions. Okay, so they're giving you an idea about neuromuscular junction. So of course they're going to affect towards your muscle. So what happened is that in this patient, basically they're having a muscle weakness and fatigability as well. So if let's say, especially when after a repeated use, so patients might be having a difficulty on the basic activity like the eye movements and the swallowing as well. Okay, whereby if let's say they are using this anticholinergics, they can't fix the underlying of the autoimmune problems. They can increase the availability of these acetylcholines. So you can use these acetylcholines at the junction. They can giving a better chance for binding to the field receptor as well. So making them quite useful at the early stage of this disease. Okay, so again, because they already destroy the nicotinic receptors, so we are hoping if let's say you have more of this SCH, so this SCH able to bind they have more high chances to bind towards the receptors. Okay, so for example, we have certain type of medication. If let's say you still remember, we are in the previous slide we talked about the neostigmines. So the neostigmine basically they often prescribe to have a temporarily kind of like improve the muscle strength by prolongs your SCH action as well. So whether that we block your SCH release or we boosting up the effects, so these pharmacological tools can give us a very powerful kind of like methods to modulate your neuromuscular transmission, either for better or for worse as well. Okay, so thank you for your attentions, and if let's say you have any questions and need further clarification as well, so feel free to drop your questions in the chat box in the My Times, or you can send me a prompt on the Microsoft Team. Okay, so I'll be happy to help. See you next week.